Good evening. It's a pleasure to be with you tonight online. And today I'm talking to you from Dubai, and I'm happy to share with you today. We're going to discuss this how to integrate minimally invasive anterior implant therapy in our daily practice. So for those of you who never been to Dubai, this is one part of Dubai actually where I work. This is in Marina. I'm right now here in this building and in the clinic, and I'm talking to you, broadcasting from here. So today we're going to talk about minimally invasive anterior implant therapy. When we say minimally invasive, that means in the cases where we still have tissue to preserve and we still have all the biology is still there, and the patient is coming to us to replace the tooth. We all face these kind of situations where patient comes having problem with anterior tooth, and we know how important is an anterior tooth for the patient. And like in this case, patient came to me and he had multiple attempts to treat this tooth by root canal, but it was always failing. And he knows that I'm an implant specialist, and he comes to me to ask me what I can do for him. So patient comes, sits in the chair, and then show me the situation. And then he looks in my eyes, and tell me, okay, doctor, what you can do for me? So at this moment, as we all face this kind of situation, we have to answer the patient. We have to give him a solution. And it's very important at that time, whatever we say, we have to say it right from the beginning. Because the patient, once we start, we cannot later on change our treatment plan. So what comes to your mind when you have this kind of situation? The first thing that come to my mind, like, okay, we know that this tooth is not savable anymore, and the orthodontist cannot save it anymore. So, and we can see already the bone loss in this area. So we need to remove the tooth. One option is to remove the tooth, wait, and then come back, and then plan the implant. We all know that this used to happen in the past, but in our time now, this is not acceptable anymore, because we know that by removing the tooth, we're gonna have a lot of shrinkage. So we're gonna have maybe up to 2-3 millimeters vertical shrinkage, 4 millimeter horizontal shrinkage, and then the papillas, we will lose papillas here, and then rebuilding everything will be even more difficult. So we have to think about something else. Another thing can come to my mind is removing the tooth, doing a socket preservation, and come back later and place the implant. This is a little bit better option since we are preserving the bone, but still it has advantages and disadvantages, and we're gonna discuss all these options in details. The third option, which is my favorite whenever is possible, is to do extraction and immediate implant placement with immediate temporization, and then with also socket preservation, with grafting as well, or what's called, also described by Salama, as a dual zone technique or surgical veneering technique. And one more thing can come to our mind, and this is something that we see very often these days in the social media and in the lectures, is partial extraction therapy, or socket shield, or root membrane technique. So this is a technique that consists of leaving a part of the root, especially the outer aspect of the root, to support the buccal bone and to maintain the blood supply for the buccal bone, and place the implant behind it. And we can see reports like maybe up to 10 years, and it's still the technique it needs more follow-up, but it shows also excellent result. However, it has a limitation, and we have to be very selective when we do this kind of technique, and we have to be very also experienced, as well as it's technique sensitive a little bit. So, but these are the options that come to my mind. But honestly, there is no magic recipe to give to the patient. We have to assess the situation and do a proper diagnosis and choose which option could be good for our patient. In this particular patient, we decided to remove the tooth, and then what was in my mind is always preserving versus rebuilding.
So always, whenever we have tissue, we have to try to preserve, because always rebuilding is more is completely different approach, is more complicated. So today in our presentation, we're going to focus on minimally invasive and preserving. So whenever we have a situation where we can preserve the tissue and replace the tooth. So here the tooth was extracted, and in this particular case, I decided to do socket preservation in order to preserve the tissue to have a successful aesthetic outcome. So how we do a socket preservation? There are many techniques described where you can put the bone graft and put connective tissue graft on top, or do a palatal flap. So, but we use the most simple way. And in this case, I use like the ice cream cone technique described by Tarno. As you can see you can see the article if you like to see it. So basically, what we do, we pack a collagen membrane, and behind it we pack the material, and then we tack it in under the palatal gum. So now, what kind of material we can use? Arroyo, he described in many publications that you can use allograft, you can use xenograft, but the best result he got was the xenograft. You will always have a little shrinkage, but it will the presence of bone graft will limit dramatically the shrinkage. So and the best result Arroyo got was with the xenograft. So the only problem when you do socket preservation, and you have to keep in your mind that it's time consuming. So when you decide to go for socket preservation, you need to leave it to heal at least 8 months, 6 to 8 months, sometimes more, especially if you are using xenograft. If you use allograft, maybe it will heal faster, maybe in 4 to 5 months you can re-enter, but you can also expect more shrinkage. And you can see here how we finished. So why we are doing socket preservation? We are doing socket preservation because we want to maintain the bone, and we want to maintain the soft tissue contour. By maintaining the bone, we can maintain the soft tissue contour, and we can compensate on the ridge resorption. And many studies have shown, as I mentioned before, and the most famous ones are from Arroyo, from Marcos, that the socket preservation technique seems to show important results concerning bone volume conservation, and give us a better architecture for the alveolar ridge in order to obtain ideal functional and aesthetic prosthesis after implant rehabilitation. The same also Arroyo came to the same conclusion. And we know that we have always to avoid flap elevation, because once you do flap elevation, then you are already altering the thin cellular layer of the periosteum, and also you are not preserving anymore the tissue. So whenever it's possible, you have to avoid opening a flap. So you can see in this particular case after the healing. So now this is 7 months after the healing. You can see that we achieved some kind of preservation, and also our temporary, the shape of the temporary also reshaped the soft tissue. And now our socket is ready for the implant placement. This is another study by Italian group where they did around 40 patients, and they divide the patient into 2 groups. One group, they did extractions, and they let the socket heal naturally, and then they placed implant. The second group, they did socket preservation, and then they placed implant. And they compared the behavior of implant in naturally healed ridge or an implant in socket preserved ridges. And the conclusion was that implants placed into grafted extraction sockets, they have exactly the same clinical performance like implant placed into non-grafted site in terms of implant survival rate and in terms of marginal bone loss. However, in the grafted sites, they managed to place a better implant diameter, and they required much less procedures, augmentation procedures, bone graft or soft tissue graft. So implants placed in socket preserved ridges have the same performance like implant placed in completely naturally healed ridges. But this is the treatment. That is your treatment plan if you do a socket preservation. So in the beginning, so you can see again the situation how it was. So at that time, because of this radiolucency, we decided to do socket preservation, not to take any chances with the immediate implant. So extraction, socket preservation, and temporary bonded bridge. And you have to wait 6 to 8 months before you can think about placing the implant. Then in this case, we placed the implant, and then again we waited 3 months before we put a temporary crown. Then 2 months for the temporary crown before we put the final crown. So it took, as you can see, the treatment plan is like more than a year to finish one tooth. So this is really a very long treatment for the patient. Of course, the outcome was very good, very predictable. But nowadays, the patients, not everyone will accept to go through that long treatment. So it is a very valid treatment way, but we have to really do it when it's really indicated, when we can really help the patient by doing only this modality of treatment. So here again, you can see a view. The implant was placed flatly, and this is the temporary crown. So we can see clearly how the soft tissue healed around the temporary crown. And notice the gingival margin, the gingival level. So that was the initial level. And then with the temporary, actually we gain more tissue. And you can have occlusion view also after loading the temporary. So it's quite stable tissue around the implant. And that's, you can see this is the final. So that's how the patient started. And this is how we finished the case. So you can see papillas are in place, aesthetically, functionally, everything looks nice. Here another case where we had to remove the tooth. Also the patient was aesthetically very high, she had very high aesthetic demand. So we decided also in that case to go through socket preservation. And you have to know that placing the implant will not avoid the socket shrinkage. So that's we're going to discuss on the next step as well, what we will do when we place the implant. So here extraction is done, and socket preservation the same way. You can see the socket here, we fill out the form. It's very important when you do your temporary bonded bridge in socket preservation that your overhead pontic will support the tissue, and that gives you a better healing at the after 7-8 months. This is the situation after 8 months. So we still had a little bit of shrinkage, but the fact that we put bone graft has helped us a lot to limit. And as Arroyo also showed in 2015, that the use of graft material in fresh extraction sockets cannot avoid the bone graft resorption, but can significantly improve and affect the volumetric reduction of the alveolar tissue. And this is implant placed flatly, and this is the temporization. Always in the anterior zone, we stick with temporization, and this is the healing after. And you can see how we managed to reshape the gum. This is the occlusion view, and by having a nice temporary, you can really manipulate the soft tissue and compensate on any small shrinkage. So in this case, we didn't even think about putting a connective tissue graft because even the patient didn't need to do that. So always we use a customized impression copy to copy the neck of the temporary, as you can see in this slide. And this is the final outcome. And we managed to mimic the same gum level, the same granite here and here and here. So it is a very predictable modality of treatment. However, it's very slow since it demands a lot of time. In this case, also another case of cracked tooth, anterior cracked tooth. So what we can do in this case? So I will show you the X-ray. This is a periapical X-ray. You can see it's all the radiolucency around. You can see the cracked tooth. So this is not a case of immediate implant placement, and also not a case of partial extraction therapy. This is a contraindication when you have this kind of crack. And if I leave everything to heal, I will lose a lot because this is all soft here. So I'm gonna lose all this, everything will shrink. So I said to myself, here we do socket preservation and let it heal, and then we can decide. You can see
how is the healing already after 3 weeks. And then we waited 8 months here. Implant was placed after 8 months, and this is the temporary crown on the implant. Okay, and you can see how, and this is the way we started, and this is the way we finished the case. So I showed you these cases of socket preservation to show you if that socket preservation can help us in many cases, and we can achieve very nice outcome. But our treatment will be long, and it needs, you know, a lot of follow-ups, especially with temporization. And this is the X-ray 4 years later. So now the goal is, can we do preservation with immediate loading and immediate implant placement, and we can be successful? Yes, we can, and I will show you all the studies, and I'll show you the cases that we can do this. But to be successful, we have to follow few steps. So we start with a proper diagnosis to assess our case, to see if our patient is candidate for this kind of modality, and then we have to also achieve a proper implant position, because the implant position in the anterior zone is a key of the success. And to be able to do immediate loading, we need to have proper stability. And we need to know our implant, the implant that we are using, because knowing your connection will allow you to play with the depths, and we want to discuss also the influence of the connection when you place your implant deep or shallow. And we have to do socket preservation, plus, if needed, connective tissue graft and temporization. So we have to follow all these steps to be able to be successful. And we're going to discuss these steps in details. And this case here, as you can see, so this is like very, it's showing very clearly the whole situation, that your implant has to be palatal, you have to graft the socket to support the tissue, and you need the temporary to support your soft tissue. There are big advantages to be able to do preservation with immediate loading at the same time. By doing that, we can optimize the preservation of the soft tissue and maintain the soft tissue contour. We can simplify the treatment and reduce the time and the sequence, like we saw before. It was very lengthy treatment. And of course, the patient psychology will be improved, because the patient will not really feel that he lost the tooth, and comfort, aesthetics. So there are only advantages. And so we start with the diagnosis. So like any implant case, we have to do our duty to check all the general factors that's affecting the situation, the general health of the patient. We have to check the occlusion, the smile line when it's an aesthetic case, see the soft tissue biotype, the adjacent teeth, and the periodontal status. We have to check the interproximal bone. But something very important I want to emphasize on it when it comes to immediate implant placement in the anterior zone, you need to do 3D scan. It's not anymore acceptable to try to place immediately implants in the fresh extraction socket in the anterior zone without checking a 3D view, because we are vulnerable to do many mistakes. Like you can, I will refer to this study by Dr. Joseph Kahn, where he is classifying the sagittal root position. So, and we have four positions. So the root, class 1 is when the root is buccal, class 2 when it's in the middle of the ridge, class 3 when it's palatal, and the class 4 when you have the two cortical are really fused to the root. So in many cases, if you take only a periapical X-ray, class 4 and class 1 can look the same on the periapical X-ray. And then how you can place the implant? Blindly. It's really very important to plan your implant position on a 3D scan. And not only in the anterior zone, but especially in the anterior zone. And once you remove the tooth, you have to assess your socket. Okay, and this classification by Fonato and Salama is very important to keep in mind, you have to keep it in mind, because it helps you to assess your situation after the extraction. So whenever you plan extraction and immediate implant placement, you have to inform the patient that you should have also plan B, because at the time of the extraction,
the buccal bone might break. You might not achieve a good primary stability when you place your implant. So always you have to have a plan B. And your plan B is maybe socket preservation, maybe only temporization with bonded temporary. So you have to have a plan B. So let's say you do the extraction, then you have to assess. The most important thing first to assess is the buccal bone. You have to see the presence of the buccal bone. Class 1 would be when the buccal bone is intact and you have a thick biotype. So in this situation, you can expect a very good result, and it's the ideal situation to do immediate flapless implant placement. When you have intact buccal bone, but the biotype is thin, it is still very good outcome you can expect, but you might also think about a connective tissue graft either at the same time or later on. When you have a buccal bone that is completely deficient or partially deficient, but still you can place the implant within the housing of the alveolar ridge, then you can place it, but in that case you will have probably to do guided bone regeneration and connective tissue graft. Whenever you feel there is no buccal bone and you are afraid that the implant will not go in the alveolar housing, then better to stop, delay, and it's not a case for preservation or for immediate implant placement. Anyway, in this situation, there is nothing to preserve. So, so class 1, class 2 are the ideal, and normally you can predict this on the 3D scan. You can see your palatal bone, you can see the weights, and the only thing that can happen, sometimes you can have a surprise when you do your extraction. Okay, so always you have to have a plan B. So, so here is the case that you saw before. The patient has had a sport accident. So what he came to me with mobile teeth, and he had some kind of retainer, but then he couldn't continue with this kind of solution. So the teeth were removed, and the plan, I will show you the plan. Now in this situation, we removed the teeth, we did immediate implant placement with socket preservation, and we did a temporary bonded bridge. So in this case, we didn't load the implants immediately. We put the temporary crowns after 4 months, and then we waited another 2 months before we did the final restoration. So already with this treatment, by doing immediate placement, we saved the patient 6 to 8 months comparing to a socket preservation. However, in this case, due to low primary stability, we didn't load the implants immediately. So here is the situation when we did the extraction. Here are the implant placed. And in this case, with this type of implants, we had really low insertion torque and low ISQ. It's like an average, okay, average. If I will do this case again, I would maybe load it at this time. But in this situation, I didn't load the case. So you can see we did, in this case, I did socket preservation, I filled the gap with bone, and we stitch. And this is something that you should not do anymore. So this I will not do again. So if you're gonna do this this situation, if you face this situation, it's better to have like a contoured healing abutment that will support the soft tissue. And once I realized this problem, I started to work on the temporary bonded bridge to try to improve a little bit the situation. And you can see by just working on the pontics, we just improved the situation a little bit. And you can see after having the temporaries in place, the situation got even much better. So immediate implant placement plus socket preservation is very important to maintain the bone contour, but the temporary restorations play a great role in the gingival contour preservation. Here are the temporary, and here is the case 6 years later, and here is the X-ray. So the case was successful at the end, and the patient was happy, but we learned that we have always to support the soft tissue. Implant position. So implant position is very important and crucial for the success. So you can see in this situation, you have always to have a sagittal view to plan your implant position. So which one is right here, which one is wrong? You can see clearly that the first and the last one are really wrong, because we're going to have a lot of resorption in this area here, and we're going to have a lot of resorption in this area here, plus the crown connection will be a problem. So these positions are the acceptable positions. And always I refer to this classification from Dr. Joseph Khan. So all the kind of articles that they all give us the same result, that the position of the implant has to be in the middle of the mesiodistal width. This is publications is by Dr. Also Joseph Khan in Periodontology 2000. So the implant has to be in the middle of the mesiodistal width of the final restoration, middle, and it has to be at least 2 millimeters from the adjacent teeth. And labiopalatally, it has to be along the palatal wall, and we have to have at least a gap of 1.5 millimeter with the buccal bone to maintain the integrity of the buccal bone and to be able to put the graft there to support the buccal bone. And it has to be 3 millimeter deep from the apical 3 millimeter apically from the free gingival margin of the new restoration. So, or simply you can follow the rule 3A 2B. So that means 3 millimeter from the gingival from the emergency profile of the crown gingival margin, and then 2 millimeter from the buccal bone. And also Marco Caneva in his publication 2010, he's advising that the implant has to be 1 millimeter deeper than the level of the buccal bone, and it has to be lingual to the position in the lingual position in relation to the middle of the center of the socket. So you can see this is the center of the socket. It has to be palatal, and okay, whatever is your bone has to be around 1 millimeter deeper than the buccal crest. So it all gives us the same somehow the same position. You can see here the implants are placed immediately after extraction, and you can see after the healing. And you can see here, so again the same, also here Boozer and Gastaldo, the same also numbers, so 1 to 2 millimeters from adjacent teeth, 3 to 4 millimeters from the gingival margin of the new restoration, and 1 to 2 millimeters 1 to 2 millimeter from the emergency profile of the adjacent tooth. And as you can see here, we did socket preservation, implant plus socket preservation, and implant plus socket preservation. What I mean by when I say implant plus socket preservation, I mean combination of implant placement and filling the gap with bone graft, plus here temporization. And the best way to control your implant position is to do, guided implant placement. Of course, this is not our subject today, but I will show you a few cases. You can just appreciate how is the planning here. That I plan to remove the root, place the implant here, and you can see the execution here. So how accurate it is. And this is the buccal bone here, and I grafted this area. So you can see the implant position and the grafted area. And implant position is very similar to the planning. Here another case as well, which is a very difficult case because you can see here, the bone is very thin, so you cannot make any mistakes when you are placing the implant. And we know that when you are working blindly, you can make mistakes. You can go more, you can do more maybe palatal perforation here. So, and you can see with the guide placement how accurate is the placement. And here we grafted the socket, so we have all bone. And you can see the immediate temporary also was back. Another case here, this is an easy case, however, we did it guided, okay, and you can see guide, and this is here the grafted socket, okay, where the tooth used to be, exactly like the plan. And the systematic studies show that we have 3 to 5 degrees and 1 to 4 millimeter, 1 to 1.4 millimeter vertical movement. And in my opinion, this is very acceptable. And in these single cases, when you are placing the implant, you can always remove your guide and check the depths and push the implant a little bit deeper if you wish, depending on the situation. So, but still, it's a great help. And this is the same case how we started and how we ended. And this is actually on the day of the connection of the final restoration. And you can see this is also again, you can see here the planning, and you can see here the execution. So all these kind of problems that you see, like you don't want your patient to come up with these kind of resorption. All these problems are position problems, but number one problem is position. So these implants are very deep, very high, very buccal. So, and of course, you have this kind of recession, and you have to deal with it if you face this kind of problem. Another kind of issues that you will have. This implant was placed immediately, and it was very buccal, and you can see it's showing, and now this is a problem for the patient. And we don't want to have these cases in our office. And okay, in this publication, they conclude that the more the implant is facial, the more you have bone loss. So our implant has always to be palatal. You can see here as well. You can see here as well. So this is we don't want to have in our practice and not for our patients. So it's very clear, position is very important. Now, once you place your implant in the right position, you need to have a good stability. Otherwise, you will not be able to load your implant. So implant stability, what is the implant stability? And let's review a little bit again what happens when an implant is placed in the bone. So the first thing, when you place the implant in the bone, you have necrosis. You have a smashed bone around the screw. So this bone dies, necrosis, and then you have inflammation. And then you have the bone starts to, we have osteoid matrix formation, which is the bone, the new bone layers start to produce around the implant. And then at 6 to 12 weeks, the maturation of the bone will start, and this will continue over years. So the more our implant is aggressive on the bone, the more we have necrosis, and the more we have remodeling around the implant. So that means when you place the implant and it's very stable in the bone in the beginning, when you start to have remodeling, this stability will get less, and then it will start to pick up. And this is actually a big advantage of the AnyRidge implant because of the knife edge threads. So the threads, they go very sharp on the bone without really smashing and compressing too much the bone. And this we will see in the next study, the advantage of this. So keep in mind that week 2 to week 6 are the most dangerous in terms of primary stability. The initial primary stability can be high, and then it will drop, then it will pick up. Okay, so the idea is to have an implant system that will minimize this dip. Mechanical stability, again, is the result of compressed bone holding the implant in place. And this compressed and smashed bone will resolve. So the more you have compressed bone, the more you have remodeling. And then the biological stability starts when you have a new bone formation and osseointegration. So we all know this graph, and we saw it many times, but this is our daily work, so we have to keep it always in our mind. So this goes and this goes up, so we have to minimize this dip. How to measure the implant stability? So for me, and the best way to measure implant stability, I follow two ways. First, I measure my insertion torque. Second, I measure the ISQ. So I use resonance frequency analysis. The advantage of the ISQ is that you can repeat it any time. The insertion torque is only one time, and insertion torque is only the resistance to shear forces. But the ISQ is the resistance to lateral movement, and this is what matters for us. So this is like a summary of many studies about ISQ, is that the average is 65 ISQ. You need to have more than 65 to be really comfortable to load your implant. If you have less than 60, this is like a low stability. And you can also add on that, on top, the value of the insertion torque. The ideal is to have 45 and more than 70 ISQ, then you can have really peace of mind when you load your single implant. 35 Newton centimeter and 65 ISQ,
is still acceptable, but you have to be also careful and give all the right instruction to the patient. Some studies has shown also extreme criteria, like in this study, they over 100 implants where they used minimum criteria 15 Newton and 50 ISQ, and still they had a very high rate of success. But we prefer always, to have higher than 65 to be on the safe side. I will share with you a few numbers that I followed, like around 50 implants in my practice, and I measured the ISQ at the day of implant placement, and then after 1 month, and then after 2 to 3 months when it was the time to put the final restoration. So the numbers that I had were, I used all of the cases we used here, AnyRidge implants. So the average ISQ was between 55 to 81, the range. So average was 76 on the day of placement. And the average insertion torque was around 40, 39, 40. After 1 month, I had the same numbers, almost the same numbers, ISQ. After 2 months, also the same number. So I didn't have any drop in the primary stability using the ISQ with AnyRidge, and this is very good to know. And many studies done on AnyRidge shows the same result. So and this is very good for these kind of cases for immediate loading. I had only one failure, and this failure actually was replaced after 1 month. Also, it was replaced immediately, and it was successful. Another thing is important in this case is the implant connection. Since we mentioned that our implant position has to be at least 1 millimeter under the crestal bone, so that means in some cases it can be 4 millimeters from the parietal. So our implant has to be deep in the anterior zone, and you cannot put a deep implant if you have a weak connection. Then you will have a bacterial pumping and you will have resorption. That's why the ideal in these cases is to have a conical Morse tapered connection where you have no bacterial pumping. And here in this case, you can follow the work of Dr. Paul Wiegel. He did a lot of studies on the bacterial pumping, and you can see clearly that Morse tapered connection is really solid and strong, and you will not have pumping. And that's why the bone really, you can put it under the bone, and the bone grows over this connection. And like this is a case, it's not an anterior case obviously, but I wanted to show. You can see on the day 1 when you place the crown, and this is a huge crown, and I was always worried about what will happen with this short implant. And you can see 2 years later, I see that the bone has already actually was stimulated and grown over the implant. And this is a result of a proper connection. So what is my ideal surgical protocol? So instead of staying 1 year like in the other cases doing socket preservation, the ideal surgical protocol is extraction, immediate implant placement, socket preservation. What I mean by socket preservation again is grafting the gap between the implant and the buccal bone, and we're going to see a couple of studies that will support this, and immediate temporization, and then 3 to 4 months later, we put the final restoration. So now, between 1 year treatment, we shrink the treatment to 3 to 4 months. You can see here, it's like a patient had multiple crowns and post, and now she wants to replace the tooth, and the tooth was removed. And we always have to keep in our mind that always resorption will happen, and placing the implant will not avoid the resorption, so we have to place the implant anticipating the resorption, and we have to support the buccal bone to try to gain more and more volume and try to reduce the shrinkage. We always have to check our buccal bone to see if we have a still intact buccal bone. And here you can see we can clean the circular tissue and the epithelium, and then we start our preparation on the palatal side. And here is the preparation side, as you can see, and here used to be the implant. So, and here an implant was placed, AnyRidge, 5 times 11.5, and you can see always we have to keep the gap, and implant has to be palatal. And the big advantage with AnyRidge that we can play with our preparation
with our preparation to achieve a good stability. So when you are drilling, if you feel that your bone is soft, or you can under prepare, and or you can even choose an implant with wider threads. Implant in the right position, we verify with ISQ, and then we have a high SQ, high insertion torque, ideal for immediate loading. Now socket preservation, like socket preservation plus connective tissue graft if needed. So this study by Tarnot, they did around 45 patients where they placed extraction, they did extraction, immediate implant placement without socket preservation, extraction, implant with temporization. Here with healing abutment and bone graft, healing abutment and temporization. And they compared the shrinkage of the ridge, and they found that bone grafting at the time of implant placement into the gap in combination with controlled healing abutment or contoured healing abutment or a provisional restoration resulted in the smallest amount of ridge contour change. So therefore, they recommend in this after this study that to place bone graft and either a contoured healing abutment or a provisional restoration at the time of the implant placement in the fresh extraction socket sites. Another study by Amato that published in 2018, also they have 4 groups. One group they placed only healing abutment, second group healing abutment and graft, third group only temporary, and fourth group temporary and graft. And as you can see on the graph in the gray, so the stability at 1, 3, and 6 months, the stability of group 4 is really very stable. So at 1 millimeter, at 3 millimeter, still stable, at 5 millimeters, still stable. So it's the same conclusion that the result of this study seems to indicate that volumetric tissue changes are after immediate extraction placement in the aesthetic area can be minimized if a provisional is immediately connected and a bone graft is also inserted simultaneously. So that's why always when we do extraction and immediate implant placement, we have to graft the gap between the bone and the implant. Especially nowadays, the implant is in the palatal, so we have a large, more than 2 millimeter gap. And so immediate implant placement and bone graft, so to achieve a proper tissue preservation. And last step, temporization. Temporization is also very important, as we saw in the previous studies. So here, in this case, or any other case, what we do, we prepare either a putty impression before the extraction, or we do a quick wax up and we make a suck down tray to use it to make the temporary. So we prepare the temporary abutment, we cut it outside the mouth, and then we pick it up with our temporary material, and then we have to adjust and add composite on the neck of the temporary. Now it's very important to design the immersive profile of the temporary, and you have to keep in your mind that we have 2 contours, the critical contour and the subcritical contour. The critical contour is actually the 1 millimeter that's immediately below the free gingival margin, the gingival margin. And this contour is important because it's supporting the shape of the socket. If this one you modify, you're going to modify your socket. So if you push it more, the gum will recede. If you make it more loose, the gum will close, will grow back. So this 1 millimeter contour is very important. Then underneath this, you have the subcritical contour. This contour, normally, always we make it concave, so we can have a thick tissue, so the tissue will grow into it. And then later on, when you have a big volume, if you wish to push it out, you can still later on modify a little bit your temporary and push it out, like we can see in this case here. So I wanted to bring a little bit down the gum, so I worked a little bit here to create more concavity, and you can see the situation here before when I did my modification, and you can see after the healing. So now I gained more tissue, and this was the day immediately after the implant placement,
and you can see here before, always implant palatal and deeper. And this is the healing. So you can see how much tissue we have. This is always supported by the temporary and by the bone graft that was placed in the socket. Always we take a custom-made impression. And in this case, I used cemented crown. So the zirconia abutment. Always when you have 2 millimeter and less, always use zirconia. And in all the cases. And there are many studies, and this is with Jung in 2007 and 2008. He shows that zirconia will be the best choice of material in contact of the soft tissue. This is the X-ray, and you can see occlusal view, and here you can appreciate how we maintain the contour. And this is on the day of connection. So that's how we started. Even you can see the crown, how big it was, and the level was much higher than the adjacent tooth. And this is the final outcome. So we managed to bring the tissue down and to mimic really the natural dentition. So the only thing that I will change in this case is the cemented crown. I always prefer to have one-piece crown and single screw-retained crowns. And this, in many cases in the anterior zone, when our screw axis is slightly palatal or at the incisor edge, is not possible for the ceramist and to have enough thickness and to do it. So that's why we used to do cemented. But then, once we have this dynamic abutment, especially for any ridge, it was a game changer for me. So the trick is actually in the head of the screwdriver. It's like a circle, like a round ball, and that engage in the head of the screw. We can correct up to 30 degrees of the angulation. So now all the anterior teeth are screw retained. All the final anterior teeth are the screw retained. With the temporary, you don't have to use it because if your access hole is buckled, you can always seal it with composite when you are using the temporary. This is here is a case where we used also dynamic abutment. Again, here you can see. This is the case. Now, once you master immediate placement in the anterior zone, you can start to incorporate these treatments in the full mouth rehabilitation. Like this patient, she needed some aesthetic work here, and she had one crown and the tooth was broken. So here, after doing the design, and we adjusted properly the gum level on all the teeth, then we did our extraction, the same protocol, extraction, always 3D scan, immediate implant placement, graft the socket, and temporization. And this is the result before, and this is after. So always one-piece crown. And you can see clearly how we can correct the angulation. Even though our temporary was screw-retained, the final cannot be screw-retained because this thickness doesn't allow the lab. He needs more thickness to do his ceramic and his frame. So that's why we have to use this dynamic abutment. And this is the final result. So one more case I will share with you where we were doing a full mouth rehabilitation, and we had to integrate also minimally anterior implant placement. You can see here we start with digital smile design. We do a wax up, and then we have to do a mock-up first. And then once we are happy with the mock-up, we check the tissue level, and then we start to work. So based on the mock-up, we designed, the position of the tissue and the emergency profile of our new crowns and new veneers. So here, patient had to replace this baby tooth. So first we cut the gum to achieve the desired level of the tissue, and this is where we want our new crown to come out from. Then we placed our implant, and we followed here a regular surgical guide. We placed our implant 3 millimeter deeper than the new gingival margin, and we did the impression and temporization, and this is the final result. And also here, we couldn't do it without dynamic abutment, otherwise it would be a cemented crown.
and you can see a scan. So we barely had enough bone to place it, and it was placed flawlessly. And this is how the case works. So that's the implant is here, the canal. And this is the new smile that the patient that had. She had veneers, crowns, implants, so combination of all the treatments to achieve this kind of result. So in conclusion, and this presentation was mainly focused on preservation. Always think about preservation rather than rebuilding whenever you can do preservation, because it's really very precious what we have. You know, when we still have papillas, we still have buccal bone, we still have tissue, the shape, the architecture is very important to preserve. You have always to preserve, and the ideal would be if we can replace immediately. And we have to keep in mind to replace immediately, we have to do a very good diagnosis and case selection, and do a proper 3D scan, evaluate our bone, and then make sure that we can place our implant in the right position, either by doing like conventional guides or computer guides, or even be very careful when we are doing it manually freehand, and then make sure we achieve a good stability, because it's not only enough to place the implant, it's also important to place the temporary. That will help us also to stabilize and support all the soft tissue. And we have to understand the implant system that we are using, so to know the connection and how deep we can use it in the bone. And always graft the socket. Always we should have 2 millimeter gap to graft the socket. And connective tissue graft, we use it whenever it's needed. Okay, and I hope you enjoyed this presentation. Thank you.